Claire, let me introduce you. So we're so happy you were able to make it here today. Claire is an experienced general practitioner with a special interest in long COVID, postural orthostatic tachycardia syndrome, POTS, mast cell activation syndrome, and ME and CFS. She has a bachelor's in neuroscience from the University of Edinburgh and is especially interested in disorders of the autonomic nervous system. In addition to working for the NHS as a general practitioner, she also operates her own long COVID clinic in Scotland. Very happy you could join us today, Claire.
I'm just looking to screen share.
Sure, yeah, we see your screen, we see your desktop.
Oh, right, I don't see it. Right, I'll get it up.
Thanks. Yes, technology can be not so fun, huh?
Yeah, everybody else can see it but me. Sorry, my husband's helping me. He's here.
Okay. I see it left. We just would like to make your program full screen.
How's that?
It's perfect. Here? Thank you.
Great. Okay, thank you. Right, better start my clock because I've got 10 minutes for Whistle Stop Tour. So my name is Dr. Claire Taylor and I'm a GP family medicine doctor in Scotland and have previously worked with ME patients. And about January 21, long COVID patients started coming through. It was a charity and often they really didn't know where else to go to get help. And I became really frustrated that patients didn't have a doctor that was knowledgeable about long COVID. They're sort of ping-ponging between specialties. So I just set my own up and I'll tell you a little bit about what I see. So I've pinched this picture just to sort of demonstrate, like the slide before, this is a multi-system illness and people can have symptoms anywhere in their body. They can have really disabling symptoms. And to sort of draw attention to down here, malaise and fatigue, that's probably what I see most. But the cognitive impairment part, there was a study that showed about 9% of people after a year had cognitive impairment. So you're possibly 1 in 10 people cognitively impaired. And of course, all the other systems. So, and credit to these people for the lovely picture. So what I hear most in the clinic, almost always, there can be sometimes a delay, but it's I got COVID and then I never got better. And that's what I hear every day is I got it and I never got better. And the most common symptom I see is fatigue, but post-exertional symptom exacerbation or post-exertional malaise, whichever one you want to call it, this is a really disabling symptom where people, they try to do stuff and then they end up in bed for a week. And it's really, really disabling symptom, sore muscles, shortness of breath, chest pain, cognitive problems, weakness, dizziness, rapid heart rate, flushing, allergy. I mean, just about everything under the sun. And one person could have all of these symptoms when I see them. And you're trying to work out what is going on. And just to note, sometimes people are often unable to work, bedbound, like severely ill. I do video calls to people who are in bed. And I wanted to draw attention to sort of a key point that about normal test results. So normal test results don't mean there's not something wrong with someone. Doctors don't tell your patients there's nothing wrong with them. It means we don't have the right tests yet. We're not doing the right tests, or they've not been invented. So, for example, if you think of condition, sort of NMDA receptor encephalitis, it wasn't discovered till 2007. And before that, I don't know what people got told they had, but it wasn't that. And just so we know about this study that looked at patients after being in hospital, they actually measured plasma proteomics. I'm not even going to attempt to even say what all these things are, but safe to say we don't test for them in real life. And they're found to be abnormal in people with long COVID. So we have abnormalities we know about, but we don't test. Microclot testing, there's a lot of talk about that just now. Again, we can only test for in a couple of places in the world. So if you're testing normal guys, it might be actually that we just haven't got the test yet. And I just want to talk about a couple of conditions that I see most commonly in a clinic, and the last talk touched on this, dysautonomia or POTS, and it's a bit like this. People stand up and try to do something and their whole body malfunctions. So it's not a rare thing. There's a spectrum of dysautonomia, POTS, orthostatic hypotension, or inappropriate sinus tachycardia, which is when your heart just goes fast all the time. That doesn't feel very nice. That's horrible. So people are going about with these symptoms. The last few are, I'm not going to go into detail, but there's other causes. And it's a dysfunction of the autonomic nervous system that controls your heart rate, your breathing, your blood pressure, sweating, body temperature. You can be in sympathetic nervous system, controls fight or flight, running away from a lion or something. Parasympathetic is when you're resting and relaxing. A note to say, if somebody's got sinus tachycardia and you don't find another cause, well, think about dysautonomia, think about POTS. People get told, oh, well, you've got a sinus rhythm, fine. But think about standing somebody up and testing them. And this overlaps with the picture of all the symptoms, the first picture. So look at all the symptoms people can get, multi-symptom again. And in my clinic, I'm trying to work out which ones have got POTS, and it tends to be the ones that don't like being upright. It doesn't feel very nice, and get blood pooling in their feet and things. 80% are female who have POTS, and obviously a lot of my clinic is female. Study in March 21 suggests 50% of people have POTS. It's maybe not quite as high as that, maybe about 40. But if you work it out with how many people in the UK have long COVID, possibly 1.5% of the population have got this, and we hardly talk about it or know what to do with it. And there was a study in 2019 that shows that, again, things are off. Cytokines are up, chemokines are up. We don't check them in normal practice. Autoantibodies. It's a real condition, and there's good evidence for that. Patients still get told it's not a real condition. I diagnose them with it. They take it back to the doctor and they say, well, so what? What's that? So we need to take it more seriously as a real condition. Not going to too much into the diagnosis, but if your heart rate goes up by 30 when you stand up and your blood pressure doesn't drop, that's POTS. You can do it with a tilt test or a NASA lean test, which is standing up for 10 minutes. I prefer that. People can do it at home and they don't crash because they've spent a day going off for a tilt test. So there's benefits to tilt tests, but actually you can get a lot of data from a stand test. And one of my patients very kindly did this. So this is somebody's heart rate going along quite happily at 80 beats a minute. They stood up, they were up at 120, and then they lay back down and it's back down. And the blood pressure is pretty stable. So that is POTS, and patients can do this at home and show it to their doctors. Amazing. There's loads of advice for anyone that's got POTS. POTS UK website, brilliant. Fluid can reduce your heart rate, increasing salt, compression stockings, and there's medications available. Another patient, not my patient, but Harry Carroll donated this to me, thank you very much, to show what happens when you take salt with POTS. So that's her lying down, that's her standing up, and this is pre-salt, this is with a little bit of salt, and this is lots of salt. Look how much her pulse has come down. Amazing. That's not even with medication. So thanks for donating that to my talk. And then the other condition I wanted to talk about was mast cell activation syndrome. This is where people react, either they have too much histamine or the histamine is inappropriately released. They come from mast cells, little cells in the blood, first line of defense. And long COVID seems to do something to that part of the immune system where they just start piling out histamine. And again, multi-system symptoms. People are often told they're anxious, and triggers vary between individuals. Anything can set it off, and sometimes nothing. So my patients aren't doing anything and they're getting symptoms. And this is the symptoms, again, like the other ones, huge amount of symptoms. If this is available afterwards, you can have a read down them all, but flushing, fatigue, headaches, alcohol intolerance, etc. It's degranulation of mast cells. They release loads of things that are not very nice, histamine, heparin, cytokines. There are tests you can do, but they can still be normal if you've got the condition, actually. So it can be helpful, but sometimes not. No agreed diagnostic criteria, tests from the libel. So if you've basically got a syndrome that looks like it, and then you clinically improve with the treatment, we can say you've got MCAS. management. Low histamine diet helps some people. Then you want to block all these histamine receptors, stabilize the mast cells, avoid the triggers, and hopefully somebody's in a better position than they were before it. Another wee word, key point, guidelines are not tramlines. The nice long COVID guideline that we use in the UK, this is the bloods that are on it. I've never seen a raised BMP. I've done loads, there will be, but you know, it's, to me, it's not as important as we don't do a D-dimer, it's not on it. And you know, we need to find clots basically. And in my clinic, I've now got people who 2 years into the pandemic have got negative blood tests for clots, normal scans for the traditional scans we do, normal CTPA. You find the clots on a VQ scanner, which we hardly ever do. And there was a paper here was talked about how they found extra clots on dual energy CT. I've been trying to find out if there's one in Scotland. I'm not sure there is. And so we need to find these clots. So, you know, we're treating things like MCAS, we're treating things like Clots, which is great. As a doctor, it's really frustrating for me because I want to put everybody through a scanner. And as patients, it's frustrating because they have waited now 2.5 years for treatment. And I think we need to move quicker. And I'm really pleased to hear we'll be hearing from people later on talking about this sort of thing. Yeah, patients don't have years to wait for all of these trials that are all about to start. So if you're going to take anything away from the talk, find the clots. Guidelines are not tramlines, and normal tests don't mean there's nothing wrong with you. The end.